Hello everyone, and welcome back to the second day of the NHS Providers Governance and Quality Conference. I hope those of you who were with us yesterday are enjoying it so far. And welcome to those who are joining us for the first time today. A few bits of housekeeping before we start. To make the sessions as interactive as possible, we'll be taking questions from you throughout the conference using the Q&A box at the bottom of the screen in the sessions. Please do submit questions. This is your chance to put the key issues for your trust on the table for discussion. If we somehow don't get to your question, we will answer it after the event. So please don't be too upset if you don't manage to get your question answered. We'll be having polling throughout the conference. Please also engage with the questions that are being asked in those polls. We're also encouraging debate via Twitter, so please do tweet via the hashtag GovernanceQuality21. And just so you know, all sessions will be recorded. Footage may be used on our website and social media channels and will be available on demand for 30 days after the conference. Lastly, if anyone has any trouble using the system, there is a help desk area in the lobby. Please click on that to speak to a member of staff for any issues. We've got another busy day lined up for you with the opportunity to hear from our panel on healing after harm and how leadership affects learning from adverse events, and also a session on building a stronger future, ensuring resilience and quality for the NHS during a pandemic. But first, we warmly welcome Professor Suzette Woodward, Visiting Professor for the Institute of Global Health Innovation at Imperial College, Honorary Director of Science at the University of West London, and author of Rethinking Patient Safety and Implementing Patient Safety. Suzette will be exploring how we can look at what matters most in creating the conditions for safe, high-quality care in what is an increasingly complex healthcare environment, and how we could approach safety in a different way. There'll be an opportunity, as I said, for questions at the end, so please do send them in using the Q&A box at the bottom of the screen. Welcome, and over to you, Suzette.
Thank you so much, and it's an absolute delight to speak to you all today. So as Ron has mentioned, I'm going to talk about creating the conditions for safe, high-quality care in complex organisations. There's a lot that is talked about safety these days, and there's a lot of terminology out there that either might be turning people off or turning people on. And let's just explore how we will progress our conversation today. In doing some research associated with the work that I'm doing, I came across the work by Todd Conklin, where he talks about the 5 principles of human performance. And I thought they really neatly helped shape the way in which we want to talk about safety in healthcare in today's world. And as you can see, there are 5 principles coming from context drives behaviour and decisions through to how people respond and act to failure matters. So I'm going to take us through these 5 principles just to see how they reflect on where we've come, where we'd like to go and where we'd like to be. So let's look at the first one. Context drives behaviour and decisions. No more so than the last year has our context really driven our behaviour and decisions. And there's a nod to the pandemic throughout all of my talk and the world that you've been working in. But firstly, what we need to do is ask ourselves some key questions. This is a thing that gets said a lot. When you look at inquiries, investigations, and so on, people go, if only we could just change the culture, that would be just wonderful. It always makes me smile, because changing the culture is most definitely not something that you can do overnight. It is not a 3-month project. And what we have to do is work out, what do we actually mean by culture? And what you should do is break it up into all of these different things. Culture are people's values. It's also their ideas, their attitudes, the way in which they have been brought up, their customs, their normality, the norms within which they behave and work, their beliefs and their practices and so on. So you can see all of these things. And all of these things have been developed over, in some respects, millennia. So when people say, all we need to do is just change the culture, well, you've got to actually unpick all of that. You have to ask, what is it about the culture that you want to change? Is it people's behaviours or their ideas, or is it their values or their norms? And then you can start working on those things. So work out what you really want to change and then change those. And then culture change comes for free. And I think when it comes to safety, what most people talk about when they want to change the culture is that they want to shift away from the kind of blame culture that we have, so what feels like an unjust, unfair culture, to one that is more fair, more open, and perhaps more restorative. And we will build on that in this talk. So when we talk about context, we have to address this whole issue of systems thinking. It is something, again, that gets bandied about quite a bit. What we need to do is think about the systems rather than the individuals and so on. So you get these kind of sweeping statements. It's all about systems thinking, isn't it? And so really what we should do is unpick that as well. So we've got our culture unpicked. Now we need to unpick what we mean by systems thinking. And what that means is that you're looking at the overall structures and patterns and cycles in your complex system, and actually realizing that there are kind of tiny components that all join together. They're the interdependencies and the interconnections of people and tasks, and the way in which they work together. And systems thinking means that what you need to do is ask yourselves, do I address one core component of that whole system, one individual incident in isolation, or do I start to think about how those events are connected? And what can I do to address those problems as a system problem? But firstly, what you need to do is also identify what we mean by the different types of systems. So the lovely work of Charles Vincent and René Amilberte, which they've put in their beautiful book, Safer Healthcare, which is free to download, What's Not to Love. So the three models of safety that Charles and René have come up with are ultra-safe systems, high reliability systems, and ultra-adaptive. And you will find all three of these in healthcare. This has been adapted by Chris Turner and myself in terms of just trying to simplify this to make it very clear and easy to learn. So ultra-safe systems are the processes are sometimes more important than the people. You want those processes to be as ultra-safe as they possibly can be, that you're reducing the risks as far as possible, knowing that we will never, ever get rid of all risk. And an example would be delivering chemotherapy or radiotherapy. Then we have the vast majority of healthcare, which is the high reliability systems. You want stuff to go on time and time and time and time again in the same way, that people and processes are as equal as each other and as important as each other. And that would be surgery, something that you want to create to be predictable, and that every tonsillectomy is the same as every other tonsillectomy, and the risks are minimized as much as you possibly can. But you also understand that sometimes they can't be, and you might need to understand that skills and adaptability and control might change. And then you get the ultra-adaptive systems within healthcare, which is probably where we feel that we're aware more of over the last few years, which is our emergency departments. Our GP surgeries, to some extent, are ultra-adaptive. You never quite know what's coming in the door. And intensive care and others lend themselves to being ultra-adaptive. So you can see that even within a complex system that healthcare is, we start to break it up into certain different ways. You can also break it up into simple, complicated, and complex. We have simple systems within our complex system. That's the ones where if you follow a recipe or a protocol or a procedure, you should be able to get the same result each time. Complicated is when they are similar to that simple system, but you need a little bit more coordination and specialist expertise, such as building a rocket and going to the moon. It always makes me smile. Rocket science is complicated rather than complex. And complex are systems that are based on all of those relationships I mentioned. And that is healthcare. We are a complex adaptive system. So the example there is raising a child. Raising one child provides you experience, but no assurance of success with the next. And they certainly don't turn out the same each time. So let's land on that. The definition of healthcare as a complex adaptive system is that it's a dynamic network of interactions, that people and processes and tasks and resources all act in parallel and are constantly reacting to each other, the other people and processes, which in turn influences the behavior, the design, and the choice of that whole system. So when we say things like we just need to change the culture or change the system, you have to realize that it's all hugely connected. Change one thing, it may actually ripple out and change multiple things, both positive and negative. So when we look at incident reporting and incident investigations, we tend to look at things in isolation, and then we tend to make changes in isolation, which really actually doesn't work for safety. And underpinning all of that are ways in which we expect people to work, and the way in which we imagine people work, the way in which we prescribe the way people should work, and then there's the reality. So a complex system, as we've seen, has within it the complicated components, the simple components, the rules, the recipes, the protocols, and the procedures. Too often, these are created by people who imagine what people's worlds are like. So the standards are set from policies on high or other kind of groups of people who really don't quite know what it's like to work on the ground. These are then prescribed and set as rules and guidance and the norms and the expectations of the people who work in healthcare. And then they become really jarring and frustrating for the people who actually work in healthcare, because they feel like the policy and the procedure doesn't quite fit. But they may not tell you that, because they'll only tell you that if they feel that you will trust them and care about them when you say, do you know what, that procedure that normally takes 5 steps, I only do 2, because you only really need 2. But they won't disclose that if they fear that you're going to punish them or there's some consequences associated with that disclosure. This is the fantastic work of Stephen Shorrock and others, which you can find on that link. So do you know actually how work is done? Now, that's a really tricky question to answer, because how can you go out beyond the rest of your organisation? In some organisations in the NHS today, we have around 11,000 staff, for example, in a typical large organisation. That's a small town. How do you know how everybody is doing everything? Really tricky, and what you need to do is figure out how you can set up systems that help you truly understand how work is done, and therefore understand the normal everyday functionality of your system. Then that will help you and others think about looking at the patterns and of the behaviour of the system and the patterns of what people do and don't do. And do you look for the interconnections within your system rather than, I've said, the isolated problems? So the second fundamental aspect of the sort of things that we need to think about in healthcare now is error is normal. And I know we've been talking about that for years, but it is still surprising that people have a very low tolerance of error. Error is not a choice. People don't go around going, I particularly like to choose this error over this error, or this mistake over this mistake. You can't remove error. You will never have a 0 error possibility. But you can try to build those systems that we've been talking about to build up error tolerance. So kind of barriers and ways in which we can defend our system against the inevitability of error. The problem is that we expect perfection and are very rarely tolerant of error, as I've mentioned. But if we've got this complex system, the more complex the system is, the more likelihood for error. It creates error opportunities and can lead people to adapt and adjust what they do. And this is a fundamental aspect of healthcare. We are adapting and adjusting all of the time in order to maintain safety, productivity, effectiveness, you name it, that's what we're doing. And we place frontline staff in more and more complex environments. And over the last year, we've placed staff in complex environments they're not used to, in areas they've never worked. And we're shocked when they make more mistakes. I often hear people saying in the press, in policies and all sorts, we don't punish people for an honest mistake. For me, it's an odd statement to make, because if there's an honest mistake, then what's a dishonest mistake? And I think in the main what we mean by dishonest in safety terms is violations, the people who kind of purposely choose to break a rule. Now, there could be an intent behind that is some kind of malicious intent, but actually the vast majority of people who don't follow a rule or don't follow a procedure, who are violating those things, are well-intentioned. They try to carry out their work efficiently in the face of poorly designed systems, poorly designed protocols and procedures. And that actually what you need to know is that non-compliance with these policies and protocols gives you a signal, a warning signal that there's a problem in the system rather than a problem with the people. Because there are very good reasons why people violate. Certainly they may never know that the policy or procedure existed. Imagine your first day in a very difficult, complex job, and you're supposed to know about the 500 policies and procedures that are on the shelf. You're not going to. You don't know it existed. But also crucially, because we've got that possible development of a policy by those people who imagine what life is like, the kind of fantasy world, it may be unworkable. And that therefore people need to work around them in order to keep people safe. So you can help staff by reviewing and simplifying every single one of your policies. Actually try to remove quite a lot of them. And insert a caveat. This policy may be adapted depending on the circumstances faced. That means you're not setting up people to fail, that if they don't achieve point 10 on page 35, that they have somehow failed it or other. The third key point is blame fixes nothing. So we've understood that we're in a complex system, and we've understood that errors will happen and errors are not choices. But therefore, if we know all of those things, blame definitely fixes nothing. Because human beings are simply amazing. They are adaptive, creative, and constantly solving problems, as I've mentioned. And we rely on people to keep people safe. They're the solutions to everything that we try to achieve. But they can be like every other human being. People in healthcare are no different. We kind of label them as superheroes, but they're not. They're just human beings who are inconsistent, unreliable. They get stressed, tired, and can be rude. They can get distracted, forget things, and get bored, and all of those things affect the safety of the care that we provide. Because no person is perfect. And it's crucial to understand this, no matter how much experience, practice, and attention a person makes. We often think that the more experienced, we've been in healthcare for 40 years, that means I'm going to be less erroneous. Or the attention that I pay to this, if I really, really pay attention, I'm going to be less erroneous. But it doesn't matter. All of those things, everything about us, means that there are potential for us to make mistakes. However, we are scrutinized. We are scrutinized to the nth degree. And even if you watch anyone doing something they do on a mundane basis every single day, no matter how hard you look, you will find those flaws in the less sensible light of hindsight. That's, as we know, such an easy statement to make. I would never have done it like this. And yet what we do is we judge people by one error or incident, sometimes for the rest of their careers. And as Sidney Dekker so beautifully puts, in our drive to pinpoint the source of suffering, so we're trying to understand why things are happening and going wrong, we unfortunately succumb to the hunt for a scapegoat. And so rather than looking at the system, we find those individuals, and that possibly inflicts even greater suffering on people around us. Because blame does these things. It implies an error as a choice, as we know it isn't. It is absolutely clearly the opposite of encouragement and silences people. If we have a culture of blame, people are very fearful of speaking out. They will not share the kind of things they're concerned about, and they don't want the spotlight to go on them. It's much easier to blame individuals and fix the processes and the systems, and it shifts the accountability from looking at that system to the individual. It's much easier to get rid of an individual rather than have to think about how can I change that system. But it doesn't change your system if you get rid of an individual. And this is what happens. When something goes wrong and you've been involved in an incident, every single one of you who is listening to this will have been involved in an incident of a sort, whatever that may be, clinical, administrative, a massive decision you made at board level. The kind of things that you do every single day lend themselves to the possibility of you making that mistake. I've made many in my time myself. And this is how it feels. You personalize it. It becomes pervasive, and it has the possibility to feel permanent. So these three words, personalization, pervasiveness, and permanence, remember them when you have staff in front of you who have been part of an incident or a number of incidents. This is how they are feeling. pretty much all of the time. It's absolutely my fault. There's a lot of I going on. I did this, I did that. It's down to me. Not my team members, not my line manager, not the system, it's down to me. And you genuinely feel it's going to ruin every bit of your life. And you also feel it's going to feel this bad forever. And this is where we really crucially need to think about our staff. Are we helping them get through this so that it doesn't ruin every bit of their lives, that they don't feel this bad forever, and they realize that there is more to it than just their fault? So this is the whole world of creating a psychologically safe environment, the whole concepts and ideology that were born out from Amy Edmondson's work, where she talks about shifting from the fear and blame by enabling people to feel accepted and respected. And that people are able to challenge when they have concerns or questions without any fear of repercussion, no matter what that repercussion might be. It could be as little as a sneer, or as little as somebody ignoring you when you've raised your hand. It could be as far worse than that in terms of people really shunning you and bullying you out of an organization. There are many, many different levels of that repercussion. And it could be that you even have a brilliant idea. This wonderful cartoon by the lovely Liz and Molly, Should I Say Something? And we've all been in meetings like that. I'm absolutely certain you have. That you've sat there thinking, I'd really quite like to raise this. I really would quite like to raise it. And before you know it, the meeting is over. And what we need to do is create meetings where people, every single person has had a chance to say something, even if they didn't want to. Give people the opportunity and the permission to speak. And then we break that psychological safety down, and people like Timothy Clark have done this in the 4 stages of psychological safety. And these are brilliant. They build on each other. So you've got inclusion safety, where people feel safe to belong to that team, that respected, accepted. And then moving on, you get learner safety. You don't learn if you aren't able to ask questions. We don't have a world of innovation and improvement without people actually shifting the way that we do things and asking, why do we do that? Then you get contributor safety. Wow, and you've felt included, you've started to learn, and now you want to contribute your own ideas. And then finally, we get challenger safety, where people can actually ask questions about other people's ideas and suggest changes to those. If you get all 4 of those, you know that you've got a culture of psychological safety in your organization. And Project Aristotle is where they started to study this. And Google actually did a study of around about 180 teams. You've probably seen this research. It's just brilliant. And they found these were the top 5 team dynamics. And you've got psychological safety right at the top. But actually, all of these 5 things matter for safety. Dependability, that we can depend on and count on people to get things done, but also when things go wrong. That we all know what we're expected to do. We have structure and clarity around our role and our objectives and our plans. It is really unkind to leave people floundering. And that we have meaning in our work, and that our work has impact. Every single one of us wants this. And it helps us create that morale and that feeling of achievement within our teams, and helps us be safer. So do your processes, both formal and informal, ensure that your staff are treated, no matter what professional background, in the same way. So think about both the formal conversations that you have around your HR processes or patient safety incident and investigations, or even the informal chats that you have. Are you treating people absolutely the same no matter what? Do you have a culturally intelligent organization? Are your staff confident to say sorry? We find so many times that people are really frightened of saying sorry. It might be admission of guilt. It means that I'm telling somebody I did something wrong, or somebody else did something wrong. And we know that for the last 2 decades, NHS Litigation Authority, when it was at the time, now NHS Resolution, have said it is okay to say sorry. And are your staff open and transparent with everyone? And do people seek to learn rather than leap to judgment and take away the fear from accountability and responsibility? These 2 words have now been associated with fear about what's going to happen to me. Will I be suspended? Will I be struck off? And unfortunately, we know that that happens to staff. And yet all we're doing when we ask for accountability and responsibility is an account of what happened and some responsibility for doing something about that account. So that moves us on to learning and improving. Obviously, they're vital, you know that. But how do we go about learning and improving in safety when what we've done over the last 2 decades hasn't quite landed? Because the kind of incidents that are happening today, I can tell you, because I've researched this, happened 20 years ago. And so why are the same things still happening? This is the brilliant work of Bob Weers and Kathleen Sutcliffe, who have written beautifully our history in safety. And it's not, and it describes the American world, but it actually is so utterly relevant for our NHS. I recommend this book wholeheartedly. So we know that around about the year 2000, or just before the year 2000, this was published, where it told us that around about 10% of our staff, our patients, are harmed by the healthcare that's provided to them by our staff. This was a small study, it was in acute care, and we know that there are some flaws associated with this, but ever since, this has been the statistic that is used continuously. 10% of our patients will be harmed. But if you look at that, there's always an opposite statistic. What about that 90%? And this comes to the world of safety 1 and safety 2. Remember that and. This work of Eric Holnagel and the resilience engineers that he works with, where he's coined the terminology of safety 1 and safety 2. Safety 1 is described as where we learn from failure, the 10%, if we're going to go with that statistic. But predominantly over the last 20 years, we've adopted tools from high-risk industries that are much more suited to linear systems. And I've just told you that we actually work in a complex adaptive system. So if we've got these tools that fit linear systems, this is why we feel like we're not getting very far. And these are things like root cause analysis and the components of root cause analysis, like tools like 5 Whys or contributory factors, fishbone analysis, and so on. They are fit very beautifully for linear systems, and they don't really tell us the whole picture. And what happens in safety 1 is if we use these tools, we improve things based, as I've mentioned, on sometimes just the one failure. And we get this personalization. I was talking to someone while drawing it up. These are absolute things that people have said in every investigation I'm sure that you've ever looked at. I will be more careful in the future is definitely not a recommendation for change. So that's where Eric and others have looked at the whole world of the 90%. The things that go okay, the learning from success, the things that we do, that the system functions, and before we know it, we've got through a day and not that much has happened. How brilliant is that? And safety 2 also helps us say, well, actually what we need to do is learn about how can we use methods and tools that are fit for complex systems. And I know that in the talks that you're going to have for the rest of the day, you're going to learn about some of those tools. But crucially in safety 2, we ask, why did it fail this time when most of the time it goes okay? This is a line that you need to have embedded into the way in which you look at safety. Why did it fail this time when most of the time it goes okay? And crucially understand that workers are not the problem, they are the solution. So as Eric would say, ask yourselves, what is happening when nothing bad is happening? I can imagine you all sitting there going, look, I've got enough time looking at all the failure stuff. How on earth am I going to have time to look at all the success stuff? But it is about simply looking at both and looking at through the lens of success. And as I say, looking at them, why did it fail? So it's not actually that different from what you've been doing so far. And in fact, if you remove those terms, safety 1 and safety 2, it is simply safety. Safety is a system that is functioning, not a system that's not functioning. Safety is something where you want everyone to be as safe as they possibly can be. So you learn from those incidents and those never events, and you learn from those deaths and those complaints and claims. Of course you do. But you absolutely also learn about how your system is functioning. And it is a key component to ask ourselves. It is all about safety and not just this new terminology, this new initiative, this new intervention. It is a refreshed view. So do you learn from both failure and success? Do you use methods and tools that are fit for complex systems? And it's highly unlikely that you do, because we're still learning about what they are. And do you ask that great question, why does it fail this time when most of the time it goes okay? Do you make sure that you see your staff not as the problem, but the solution? And be careful about your attribution of cause and effect. Do you do that too quickly? So that moves us on to the fifth principle. How people act and respond to failure really matters. And I've talked about how it feels when things go wrong. Well, how you respond is how you will make people feel better. There's this wonderful, wonderful book called Compassionomics. It's an absolute, every page is a turner in terms of the evidence associated, how compassion can affect the outcomes of your patient care, but also affects the financial health of our organizations. It is absolutely brilliant. And again, another reference that I urge you to look at. And you have choices. You can blame or punish, or you can learn and improve. You can judge, or you can seek to learn. You can be harsh and unkind, or you can be compassionate and kind. Because you need to know that at some point bad things are going to happen, either to yourself or to someone else. And what we need to do is encourage people to have someone to hold on to. So every single person needs someone they can turn to when something's gone wrong. And I always tell this to anyone, their first day in healthcare, or they've started out in their training, make sure that you have somebody that you're going to be able to turn to when things go wrong. And the way that we can help people when things go wrong is start to encourage people to think about a restorative just culture. A retributive just culture is where we seek to pay, for someone to pay. We seek to punish and sanction. We seek to suspend and discipline. And a restorative just culture is where we actually just ask three very, very brilliant questions. These are Sidney Decker's questions. And we ask ourselves, who was hurt, what do they need, and whose obligation is to meet that need? And I know that you're going to hear from the story of Merseycare, who are going to expand on what this means for them as an organisation. But they are absolutely brilliant questions, because who is hurt are the patient and their family, of course, but it's the local community, their neighbours, the people that they are interrelating with. But it's also the staff and the people that they work with, their line managers, and it can ripple all the way up to the chief executive and the directors of the board who are hurt because this has happened on their watch. What do they need? Every single person needs something different. It is nuanced, it is bespoke, it is individual. So you need to find out what people need, what information they need, how they want to be communicated, how they want to be supported. And make sure you find people who are obligated to meet that need, not just immediately, but also in the weeks and months and sometimes years that follow when things go wrong. And the most powerful thing you can do for each other is to hold them gently, as I've said, and listen, and make them be heard and be kind to them, whether something good has happened or something bad has happened, to make people feel loved and supported. But just a little quick word about kindness. It isn't simply about being nice. As I've mentioned earlier, it's kind to be clear. It's kind to give people objectives and clarity and structure and roles. And it isn't about avoiding the hard decisions. It is really kind to help people who are struggling, to help people who you might just label as being incompetent or lazy, and to give them a way out with dignity. So whenever you see someone do something really lovely, it is really kind to stop for a minute and highlight it. This is a positive approach to safety. You offer them the chance to gain some insight of things they're doing well. Highlight that pattern that's already within them and help them recognize and want to do it again. Because when people are recognized, so you're just simply recognizing what they do, they are 23% more effective. So they're 23% more better at what they do. And when they're appreciated, they're 43% more effective. So simply recognizing and then appreciating it, you have a better effective workforce. And recognition increases staff engagement and satisfaction by as much as 11%. So there is clear evidence associated with being lovely, but there's also clear evidence associated with a just culture. And you'll find this in the research associated with all aspects of just culture, that it genuinely reduces absenteeism and turnover. And it will improve your employee satisfaction and morale, and reduces the amount of formal processes and disciplinaries you go through, and therefore the money associated with all of those things. So in summary, I've adapted the 5 principles of human performance from Todd Conklin to have a refreshed look at safety. And these are the things that you need to think about. Understand that your organisation is complex, that it needs systems thinking in order to understand why things go wrong, that you need to understand the context and conditions in which people are working, their work is done, their real lived experience. Be absolutely clear that error is normal. As sad as that is, errors will happen, that variability will happen, and that even the very best people can make mistakes, no matter how long they've been in an organisation or how experienced they are. And the worst thing you can do is use blame as a solution. You will silence people, you will cover that people will cover things up, they will not want to disclose what their lives are like. It fixes nothing. It may, to some extent, make people think that you can fix something quickly. If you just quickly blame somebody and move someone on, it doesn't fix your system. And make sure your key goal is to learn and improve and not to judge. And absolutely respond and act with compassion, kindness, fairness, and respect. I'm going to leave you, because we can't not talk about the pandemic in any talk that I've ever given over the last year, with this beautiful excerpt from a poem by Amanda Gorman, The Miracle of Morning, where she talks about the pandemic. And I think it just really sums it up for me, that we'll observe how the burdens braved by humankind are also the moments that make us humans kind. Let each morning find us courageous, brought closer, heeding the light before the fight is over. And when this ends, we'll smile sweetly, finally seeing in testing times, we became the best of beings. So when we think about the culture that we want to create, those values, those norms, the behaviours I talked about right at the very beginning, what you want to do is make sure that we create a system where people can be kind, where we can be brought closer together, and that we can be the very best of beings. So thank you very much for listening, and I look forward to your questions and comments.
Thank you, Suzette. I think that was fantastic. I think it was inspiring, it was exciting, and it was very relevant. And I'm looking forward to the questions. I suppose while we're waiting for people to get their questions up, a lot of people on this call will be leaders in organisations. There'll be chairs, NEDs, chief executives or board members, etc. And they're probably thinking, gosh, I either think I've got a culturally intelligent organisation, or I'm aspiring to getting there. But this is not all in my hands. It's external forces that buffet me. There's whether it be politicians or regulators or aggrieved patients or pressure groups, that comes into that will say, never mind all this stuff, what about who's to blame? Do you have any advice as to how leaders should deal with those external forces effectively?
Absolutely. So you're absolutely right, but there are factors that can both hinder and help. So we know that there are hindering ones. There's the view of the press, the media, society as a whole, who very much want to seek to blame. I think there's a conversation that we can have in terms of what that means as a society, in terms of our attitude to error and harm. And when it comes to healthcare, we kind of do this weird thing of setting people up onto this superhuman platform. I think what we need to do is inform and communicate incredibly well associated with what goes on in healthcare. And I've seen very brilliant examples of chief executives who have been stood in front of cameras and have, with clarity and eloquence, described how complex their systems are and how much they're going to support their staff, how they acknowledge that it's not good enough in the respects of harm, and they're constantly seeking to learn. So we really start to use that language constantly. If we all do that, then we start to push back slightly in addressing that. What we know is we also have some things that help. So there are some amazing groups. There are some people you can work with. Obviously, people groups, that people who work around all of this. Public engagement, public involvement. We can get them on our side to start to be part of our community, not on the other side of that community. So you can create a shared purpose and a shared agreement of what we're all trying to achieve. And we know they exist both individually and groups who are really supportive of this way forward. The restorative just culture is for all of us because it restores both patients and their families to a place of some element of healing, as it does staff. So that we can, the more we can describe all of the benefits of all of this, people start to realize, do you know what? It actually might help me, be better for me, and ultimately be better for others around me, that the systems could be safer as a result. So it's kind of selling it, setting it up, informing it, communicating it, and understanding it. I know it's a long answer, but there are never any short answers, any of these things.
It's a very relevant answer, thank you. And a related question really coming up from a colleague. As a leader, what would you say is the first thing I can start doing today to move to a more open learning working environment?
The crucial thing is to be really humble and realize you don't know what life is like. You might assume it is, and go out, walk the floor, talk to people, listen, and hear what people's lives are like. That shows them, and again, in the pandemic, we've heard of some amazingly fantastic stories where people have said, my executive came out from some kind of cupboard or whatever, became really visible, and I felt like they were there with me. I felt like they were starting to really understand what my life was like. So become visible, go out and speak to people. That's the very first thing that I would do.
Okay. There's a colleague frustrated that quality and performance committees have an agenda that's focused on never events, adverse incidents and the like. You can imagine that background. And the question is, how can NEDs change it to safety too?
Yeah, so NEDs can ask those crucial questions. Why did it fail when it doesn't normally? Also, how do we know what it normally is like? So in terms of our functionality, we've got this sweeping statement of it's 10% failure, 90% things going right. What do we actually know about some of our systems in terms of their propensity and proportionality for going right? So you can ask some questions about your system. Surely it normally functions okay. What can we learn about the fact that it functions okay? And what can we learn about the fact that it might not have done? Some really nice things coming into the system. So when we talk about helping factors or things that will help nudge, is that you've got the newish now, it feels like only yesterday, the NHS patient safety strategy, but we've also got this thing coming through, which is the patient safety incident response framework. Now that I know that doesn't get us away from never events, but what it is starting to do is it's going to introduce a different way of thinking associated with serious incidents. We're not even going to actually have that term anymore, and we're going to actually move away from serious incidents to looking at patient safety incident investigations. And they're stressing the need to look at that from a safety 1 and safety 2 perspective. So we're starting to see that national policy is going to start to drive that behaviour. But also associated with that is the patient safety syllabus, which is 2.0 syllabus, was launched just a week ago, which talks about helping your staff embrace this whole new concept and start to learn about it more. So we've got this patient safety incident response framework, the patient safety syllabus coming through, and those will nudge us and help us think differently as well. So that will help the non-exec directors to ask questions. How are you implementing your strategy? How are you implementing this framework, and how you're implementing the syllabus? And what's our patient safety specialists doing about that? Because every single organization will now have one.
Yeah, thanks. I suppose I'm just reflecting on the forward agenda. We're in a movement from an organisational focus to a systems focus, as you know, at the moment. And I'm just wondering, in this context, what do you see as the opportunities and the threats of that sort of transition for this agenda?
I think people are frightened of missing something. I think that so the threats, I think that we know that in terms of the safety 2 world, there's an attempt to turn people off because they'll think it's some new fad, some new initiative. So there's that aspect. They might feel you're going to miss something associated with the old way of doing stuff. So we investigated, we looked at incidents, we looked at incident investigations that told us something. So you can hold on to something at that point. I think the challenges and the threats are the fear that sometimes change obviously brings, in terms of this might change my role, my job. I might not even have a job, which is not true at all. But you know, that if we're moving away from this part of safety and moving into another, do I need more skills and different skills? So all of this change brings up all of these things that individuals start to really worry about, and that can threaten people, that they hunker down and want to just continue doing the same old.
Okay. Sort of there's a question which is sort of related to one of your earlier answers about the media, the blame culture, the blame focus of the media. Can I ask in a specific way? We are, as you know, about to have a new NHS chief executive, or whatever title we give them this time. What would you want or hope that individual would do in this space to change the sort of debate in this subject area? You know, what if you had your question at their interview, what would you really hope they would aspire to do in those early months to get on top of this agenda nationally?
I think what I'd like them to do is believe that actually the way forward in terms of looking at systems, moving away from blame, looking at a restorative just culture, believe that it is the right thing to do. Because when you believe it, it comes out as genuine from you. So not only believe it, understand it, role model it, and make sure it's consistent. So the trouble with when you are, and you'll know this intimately, but when you are very, very senior, you can have a certain level of behavior that is lovely when things are going okay. When things don't go okay, then we resort back to those norms, behaviors, that culture that we had of command and control, blame and punishment, and so on. What I'd like that person to do is understand it, truly believe that it would make a difference, and be consistent no matter what happens. And that's an incredibly hard thing to do when you've got scrutiny, public committees, the press, politicians all saying to you, I'm sorry, but you just need to hold these people to account, or fire these people, or do whatever. And you've got to be consistent if you can do that. And that's a really hard thing to do. I get that. But if we all did that, then that would be my wonderful ask.
Great. I'm sure that's a good question to ask them. Can I a really important related question, I think, behind some of the issues around this? It's what needs to be in place to address the focus on inequalities at ICS level. In other words, how do we get the whole equality agenda properly reflected in the debate we're having? I know you touched on it from time to time.
Yes,
but you can imagine the manifestations of this in here.
Inequalities or equalities are crucial to safety, in that we know that there are groups, people, individuals, depending on how different we are, who get marginalised. And we've seen that across the whole last year, but we've known about it for years and years. If we take it just down to very individual focus in relation to individuals within organisations, their ability to speak out, this will then mirror, then you can ripple that up and beyond, right across your systems. If you're going to treat people differently and they don't feel that they can speak, whether it's their gender, their ethnicity, their sexuality, their whatever it is that makes them different, you're going to miss something. You're not only going to miss the things that people are concerned about, you're going to miss the brilliant ideas. So it's back to that psychological safety stuff and that inclusion safety that Timothy Clark speaks so beautifully about. If you start to really try to work on those, you will address a lot of those inequalities. But we have to also accept that differences are to be embraced as much as to be concerned about. The embracement of the fact that different cultures and different people bring more brilliance and more wisdom to that group should be embraced and celebrated. So the more we can do that, the better. So that people can not only feel safe to speak out, they can feel celebrated to speak out. And that will go a long way, I think, across the whole system.
Great, thanks, Suzette. A good way to end the session, I think. And I think this session will have given people a lot of food for thought. If that is the case, then they can join the session at 12:30, where you will be hosting a conversation with trust leaders as to whether we can be more problem sensing in the NHS, and I'm looking forward to that. So thank you again, really, really great contribution, and we'll see you later on. Thank you.